Case study by Sharon, a student at East Tennessee State University. So a geriatric syndrome can be a cluster of syndromes or a single syndrome that involves a multiple organ system and is usually present in the older adult. For my patient, she is defined as pre-frail because she does not yet have three or more of the physical criteria that defines frailty, and those are weight loss, exhaustion, physical activity or a lack of physical activity, decreased walking time, and grip strength. There's also a correlation between being frail and getting older. And as I hinted at, frailty is not, there's not one definition for frailty, but it's recognized as a person's inability to return to their baseline or to their homeostasis after they've experienced a stress, and there is an increased risk for adverse outcomes for these patients. According to the literature, up to 50% of people older than 85 are considered to be frail. Women are more affected than men, and those with lower incomes and lower educational levels are also affected more often than their counterparts. Frailty is expensive. It places an economic burden on families, on the patient, on the communities they reside in, and on healthcare organizations. And because there's no comprehensive definition of frailty, then there's no set interventions that help prevent frailty. Although studies do show that prevention of frailty has the potential to improve outcomes in older adults and thereby enhance utilization of our healthcare dollars. And we as nurses and future practitioners, we can help lessen the impact of frailty by determining if there is a pathological cause for a person who is weak or fatigued, and then implementing interventions that help address that cause. So my patient that I chose for this case study is the same one that I used in my comprehensive assessment. She's a 69-year-old female. She has no known allergies. She is on antidepressants. She's on anti-diabetic agents, antihypertensive agents, and she also uses over-the-counter Tylenol for any pain that she experiences. Her immunizations are up to date. She received her childhood immunizations. She's also recently had a TD vaccine, the Prevnar 13, as well as the PCV 23 vaccine and the Shingrix vaccine. She did receive a flu shot for this past flu season. Her medical history is interesting in that at age 7 she had burns to over 70% of her body. She did this because she mimicked a person that she saw on the Ed Sullivan Show who had flaming batons. And so this was something she decided that she wanted to do at home. And so this did not end well for her. She actually had on crinoline petticoats, and the stick that she was using that she did light on fire ended up burning her. And so that was one reason I chose this patient, because she had such an interesting history with that accident that happened at such a young age. She also has diabetes type 2. She has hypertension. She was diagnosed with bipolar depression, and she uses tobacco. She's had multiple hospitalizations and reconstructive surgeries over the years. Most recently, she had reconstructive surgery in 2017. She lives alone in an apartment setting, and her son and his family live nearby. For her health maintenance, she is fairly up to date with all screening tests. She's had a mammogram in 2014, colonoscopy the same year, 2014. She is not sure if she's had a bone density test, and I do address this later in the presentation. She does have a history of bipolar depression, and prior to this recent skin cancer diagnosis, does not have any prior diagnosis of skin cancer. No known exposure to TB. She had a hysterectomy when she was younger for uterine fibroids. She does wear corrective lenses, and she does plan to establish care with an optometrist in the future. No concerns about her hearing. She is a smoker and has smoked for a number of years, so she would be eligible for a low-dose CT scan of her chest. And this will be addressed, this and the cardiovascular risk factors will be assessed in the near future because of the pressing concern is this squamous cell carcinoma that she was diagnosed with in this non-healing wound on her right buttock. As I mentioned, the non-healing ulcer to her right buttock is the reason for her presentation at this visit. She has had this for the last couple of years. As I mentioned, she had the burn history, and so she's endured multiple hospitalizations and multiple reconstructive surgeries for her skin and tissue injury that she had as a child. So her initial presentation, like I say, to this office was for this non-healing ulcer. And so in the clinic where I was precepting, there is another surgical clinic that actually has a wound care specialist. He's an MP and he is certified in wound care. And so this patient was referred to him, and she saw him on the 8th of January, and multiple medical modalities were tried from January through the middle of February. And so finally, he excised the wound and sent it for pathological examination. And that's when the diagnosis of the squamous cell carcinoma was finally found, and was the reason that this wound would not heal. And again, this patient, she's not presently frail, but she is pre-frail because of her comorbidities. She does have upcoming reconstructive surgery. And since frailty is often defined by a patient's physical capabilities, she meets the criteria because she does have some challenges. Um, her challenges are fatigue, some limited mobility because of her previous surgeries and scar tissue, which affects her ability to perform physical activity. Common complaints for frailty include weight loss, weakness, lack of energy or endurance, slowness, and lack of physical activity. For her review of systems, her head, ears, eyes, nose, and throat, her GI system and her GU system, hematologic, neurological, and cognitive systems were all negative. And I've listed the pertinent positives below. She does have fatigue, pain in her right buttock that she rated at a 4 out of 10 at that visit. She has extensive scarring to her buttocks, her posterior legs, and lower 2/3 of her trunk and thighs. And other than that, she does not have any other rashes or lesions. She does report a hacking, non-productive cough, especially of the morning. She does have that smoking history. She has a history of hypertension. She checks her blood pressure at home, and her readings, she said, are consistently less than 140/90. However, with this recent diagnosis, she has been feeling more stress, and so those numbers have been up. She also has a diagnosis of diabetes type 2. She has not had any hypoglycemic episodes, and her current fasting blood glucose levels are between 110 and 140. She does have the scars, as I mentioned, and she said she did have an episode where she felt sorry for herself, had a little pity party over her cancer diagnosis, but now she wants to get this taken care of. So this patient's vital signs were stable in the office. She is slightly overweight and obese. Cranial nerves were intact. Most of her positive findings centered around the skin assessment and specific to the right upper buttock. She did have a wound there with a dressing on it, and only a small amount of serous drainage was noted. There was no erythema or any other concerning signs surrounding that wound. Her coordination was good, and I wanted to focus on this because of the extensive scarring of her skin and wanted to be able to obtain a baseline setting at this visit of what she was able to do. I did think that she was overall weak. I rated her a 4 out of 5 for her limb strength. All her other findings, like I said, were within normal limits, and she is independent in her ADLs and in her instrumental ADLs. On her screening tools, she did meet the criteria for pre-frailty on the frail questionnaire. Her other screening tools, the NRSE, the Geriatric Depression Scale, and the Tenetti Gait and Balance Scale, were all unremarkable. So like I mentioned earlier, this patient's not sure if she's ever had a bone density test, and she is a new patient to this practice, so we did not have any indications in the chart that she had ever had one. So that would be something to consider in the future. Other tests to rule out causes of fatigue include CBC and ESR, electrolytes, BUN, and creatinine, also her protein status, as well as thyroid status, as well as an UA. And labs have been collected for this patient at a previous visit that was less than 30 days ago, so no new labs were collected or ordered at this visit. The progression of frailty in this patient includes sound nutrition, uh, encourage physical activity, cognitive training, and measures that address psychosocial well-being. Some studies also suggest protein supplements as well as vitamin D supplementation and reducing the number of medications that the patient's on. The differentials that should be ruled out when the patient presents with fatigue or weakness include hypo or hyperthyroidism, heart failure, infectious disease processes, lung pathology, sleep apnea, anemia, or autoimmune disorders. And these differentials have been ruled out at earlier testing for this patient. The other thing that was addressed with this patient is smoking cessation, and she said she was not interested until she recovered from this next reconstructive surgery. So as I mentioned, she is facing yet another surgery, so I think appropriate community resources include home health and physical therapy. Home health specifically for dressing changes and assessment in the wound, and physical therapy to help preserve her functioning. Other team members could include nutritional support services and also case management, because she's going to need ongoing resources. And depending on what the future treatment plan is, case management would be an integral part of her therapy. And then with the diagnosis of depression, there should also be some component of mental health services to help her as she goes through this diagnosis and her future care plan. So this patient is at risk for frailty because of her low physical activity, her tobacco use, her comorbidities, fatigue, and polypharmacy. She's at the lower end of the economic status as well as educational level, which does predispose her to frailty. She's facing another surgery, which will be another financial burden. And if she cannot care for herself, then those ethical and legal issues will have to be addressed as time progresses. So it was interesting to read about frailty and how we as practitioners can affect change in patients before they become frail. So like with this patient, addressing her medication regimen, her physical rehab, and her nutritional status will help prevent further deterioration in her physical status. Thank you.